how to perform a retrograde CTO using one 6 French guiding catheter and one microcatheter. No disclosures. We presented first of this case series on 2022, and we called this technique prospect technique. Introspect technique, the meaning of the word is reflective looking inward. And further on, we will know why we named this. The case was a 65-year-old man presented to cardiology clinic with recent onset of typical exertional chest pain, and which was a bit resistant to the medical treatment. So we decided to further assess this patient. This is the angiography of this patient, which showing a total occluded LAD from first septal with a retrograde of the same left side from a very well-developed large septal. So as the case showed, it was a blunt stomp, 30 millimeter of total cut. We decided to go retrograde as we were worried about just damage if we performed ADR in the first part of the LAD to the very large septal and very large diagonal. So we decided to go retrograde from this ipsilateral collateral. So we wired first the septal, but cyan blue wire, Caravel 150 microcatheter, and it was easily passing through the septal to the distal LAD. So we had no issues passing the microcatheter to the mid part of LAD and performing a distal cap puncture. We used Gladius wire to perform this, and it could easily go through the antegrade guiding catheter. Then we could just transfer the microcatheter to the this guiding catheter and externalize with RG3 wire. So from this point, we could just do some variations of this technique, performing the predilation ballooning over this RG3. We could just use antegrade microcatheter, or we could use the tip-in technique or rendezvous, no difference. And performing the predilation, we could just pass the antegrade wire again and easily working over the antegrade wire to perform the PCI and performing a stenting of this proximal LAD. This is the image after the predilation and wiring. So we implanted the stent at very proximal of LAD, and this is the final result. And this is the whole scheme of this technique, performing just with one 6 French guiding catheter, antegrade microcatheter, which gets back to the guiding catheter, and following that, we could just perform it with over the RG3 wire or antegrade wire, performing a tip-in technique. Why do we need to accomplish CTO PCI? Still, after performing many of the trials, we don't have the survival benefit over performing CTO PCI. And still, when there is a symptom-resistant patient, that's a 2B indication. And why is that? Because we have many complications performing CTO PCI. Perforation, mortality also is higher in the performing CTO. And when you perform the retrograde, all the complications actually doubles 3 times higher in the retrograde CTO. And this is the whole image of this journey from 1977, which was performed first, and now in 2025, lately we introduced HDR, TDADR, and still the journey is going on. And do we really need to check viability ischemia? We don't know. Actually, if this is a large territory, we might be able to assess this territory via viability and perform the CTO PCI. Well, proper case selection and anatomical understanding drives success. Retrograde CTO PCI is feasible with a minimalistic, efficient setup. Septal collateral remained the backbone of safe retrograde access. Successful retrograde externalization facilitates control antegrade work, and treating CTO is not about opening arteries, it is about restoring quality of life. Thank you very much.